Welcome everyone. First, a huge thanks to Système team and Professor Talarico for their kind invitation to participate in this sixth event of Système and Demand. My name is Dr Zadikian. I'm from France, Paris, and I specialize in implant surgery with, let's say, a strong passion for digital workflows, immediate implant placements, and immediate loading protocols. And in addition to my clinical work, I'm also involved in oral health research at Paris University. And I have also the privilege of being part of the FOP training team alongside my father and my sister, where we share our knowledge to fellow colleagues. And today I'm excited to talk about digital workflows and supra-crestal attachment systems and how to seamlessly integrate biology and aesthetic in single tooth restoration, and I look forward to share this with you today. So, since the early days of implantology, our focus has evolved significantly, and today OSEO integration is no longer seen as a problem. It's expected, and what truly matters to our patient now is the aesthetic outcome of their restoration. And with rising aesthetic demand, we are faced with the challenge of ensuring that peri-implant soft tissue blends seamlessly with the surrounding natural gingiva. And this is what we call muco-integration, achieving a perfect harmony between the pink and the white. And for long-term success, several key factors needs to be in place, and I would like to start by exploring these essential conditions before diving into the digital workflows that made this case possible. The quality and volume of peri-implants of tissues plays a crucial role in achieving a successful aesthetic outcome, and especially in cases where we need, as you can see, a well-scalloped tissues with longer papilla, like in this case. And research now suggests that creating soft tissues around implants is essential, and not only for aesthetic but also for improving hygiene access, and this which ultimately contributes to long-term stability of our treatment. And as we'll see, I think that this philosophy is an effective way to prevent peri-implant diseases and before they even develop. And achieving harmony between the pink and white is even more crucial when the periodontal is visible in a patient's smile. And I often hear colleagues that say, "Oh, my patients doesn't show their gums when they smile," but what is the reality of periodontal exposure? This study answered this question by showing that during a natural smile, approximately 55% of patients expose their periodontium, meaning that nearly 45% do not. But when these same patients are asked to force a smile, however, these same patients only 11% no longer expose their periodontium. And this means that aesthetic considerations are relevant for 90% of patients who reveal at least their papilla when they smile. So everything we will discuss today applies to 9 out of 10 patients we see in our daily practice. And myself, I consider my tissue objective successfully achieved when I have managed to align the tissue corridor with the prosthetic corridor. And the immediate consequence of this is the alignment of the peri-implant sulcus with the periodontal sulcus. And at this point, the peri-implant sulcus become fully accessible for brushing, ensuring better hygiene and long-term stability. And this is very important, as we know how important are statistics about mucositis and peri-implantitis. So now let me show you how we proceed with this patient, and here is the initial situation we started with. And after the extraction of tooth 1, 2 and immediate implant placement, here is the result of the tissue regeneration procedure. And but before I show you how the provisional restoration and biomaterials played a key role in this process, I wanted to show you this study of January in 2008 that showed that when performing a CBCT scan without a retractor, the lip naturally covers the buccal tissue and the tooth, limiting visibility. But when you use a retractor, this tissue are pulled away, allowing us to precisely visualize the marginal gingiva and its relationship with the marginal bone. So here, let's take a close look at the marginal gingiva, which here you can observe that the marginal gingiva, you can observe not only clinically but also in relation to the implant platform, which is here clearly visible. And now if we focus on the marginal bone level, which is also evident, my objective is for the implant platform to be positioned 2 to 3 millimeters supra-crestally after healing, and even if it wasn't at that level before our regeneration procedure. And to help you to visualize the bone contour around the implant, just take a look at this image and imagine a volcano, and I want this kind of shape around the implant platform with my bone at the end of the treatment. And in terms of horizontal positioning, my goal was to achieve 2 millimeters of bone volume between the external cortical table and the implant. The intra-tissue relationship are also crucial to observe before and after treatment. Before extraction, the vestibular bone is very thin, which is why it is essential to create additional bone on the vestibular side of the implant, as you can see here. And studies show that anterior cortical plates are on average thinner than those in the posterior area. And this is not just something to memorize, it's something in fact that can be measured directly on the CBCT scan, and that is very important. And only 2.6% of the population naturally had an external cortical plate thicker than 2 millimeters, which is precisely what we aim to achieve after our procedure. And when the vestibular bone is 2 millimeters or more, additional grafting is not necessary. The blood clot alone is sufficient for healing, and however, as you saw, this applies only to 2.6% of patients in most cases. So in most cases, bone augmentation is essential. And in the same way, there is some variation about epithelial attachment. According to literature, it can extend up to 9 millimeters without necessarily being classified as a periodontal pocket. And in cases where the external cortical plate is absent, the treatment protocol differs, and we will explore this in more detail after. So now, take a close look at the supra-crestal attachment system and how it has formed in an aesthetic position thanks to the careful adherence to the key principle I've mentioned. The junctional epithelium acts as a semi-permeable membrane, enabling active interaction between the microorganism in the oral cavity and the host immune system. And this interaction plays a crucial role in preventing bone infection. And this is very important, and this explains also the implant survival rate in this context on immediate implant loading, and explain that the implant survival rate in this context are not negatively affected. And the concept of supra-crestal attachment system healing leads us to follow this recommendation of those authors. When the marginal gingiva is in the correct position, the implant should be placed 3 millimeters apical to it. And if the gingival is not ideally positioned, then the implant should be placed 3 millimeters below the prospective gingival margin. And through this radiography, I want you to show you that this is not at the end a prosthetic extension, but a true supracrestal attachment system with a sulcus that remain accessible for hygiene and maintenance. It is very important. And the main point to remember is that by integrating aesthetic into my treatment plan, I'm automatically ensuring proper hygiene access. And at the same time, it's essential to assess long-term outcome to establish and validate an effective tissue management strategy. So with this in mind, I've selected another case done by my father that I want to share with you, and this to show you how we manage those situations before without digital workflow, and I will show you after with digital workflow. And this was back in March 2010, 15 years ago. And here is how here at the FOP campus we used to teach extraction and immediate implant placement without digital technology. Drilling was done palatally of the apex in a flapless approach. Implant was placed, and even without digital technologies, the same key principle applied, ensuring 2 millimeters of bone volume, just as I described earlier. And at the time, temporary tooth was fabricated manually. So back then, this was our version of digital technology, taking an impression of the extracted tooth to ensure the fabrication of the provisional restoration. So at this stage, we will capture the anti-rotational plastic coping of the provisional abutment to ensure precise adaptation. And this is where you will see how digital technology has overtaken analog method, allowing us to achieve the ideal shape of the emergence profile with greater precision and predictability. And this is crucial because the idea will be to utilize the provisional to gently compress and shape the biomaterial placed within the socket, and this to ensure optimal adaptation and stability of the bone graft. And since the epithelium is shared between two teeth, we use a tunneling instrument to make a proximal incision, and this allows us to place the bone substitute under the contact point, and which will be a key to obtain a long papilla. And by placing the biomaterial in direct contact with the provisional restoration, the extraction, immediate implant placement, and immediate loading protocol was then successfully completed. This patient has been followed up over the years, and in 2022 I personally saw her for follow-up consultation, and I took those clinical photos that you can see. And I would like to share with you the cone beam, the CBCT, taken 12 years after, that is providing us valuable insight into the long-term stability of the treatment. And here you can clearly see that the marginal bone, the implant platform, is positioned in 2 to 3 millimeters subcrestally, once again, at the and you can see also the supra-crestal attachment system. And through each of the clinical cases, we've demonstrated that the aesthetic success can be approached through the lens of biology. So let's continue. Now let's take a look at Julien, who underwent unfortunately an apical resection that did not age well over time. And in this case, we had the advantage of having a good interproximal bone level, both medially and distally, and this ensuring papilla preservation. And to confirm this, I check on CBCT if the distance between the crestal bone peak and the contact point is less than 5 millimeters. So here, the chance of maintaining a fully formed papilla are significantly higher. The key challenge in this case is to rebuild the lost buccal bone plate, ensuring both biological stability and aesthetic integration for long-term success. So Here, an access flap was created while preserving the medial and distal papilla. A partial thickness incision was made, followed by the removal of the epithelium from the papilla. Next, the implant is placed, a connective tissue graft is stabilized, bone augmentation is performed to restore the buccal bone plate, and the flap is closed by primary intention. So here it was a two-step surgery, and here again the provisional restoration will have a key role. Why? Because to help to guide soft tissue management, as you can see. So this is Julien 7 years after, and where we achieved to align both sulcus for aesthetic but also for hygiene. And the outcome met once again the requirements described earlier. So let's take a look at this study from Tano in 2015. He highlighted once again how crucial is the provisional restoration. Here, different approaches were assessed, with or without provisional restoration and with or without biomaterials to demonstrate their impact on bone and soft tissue preservation. And they demonstrated that the procedure combining a provisional restoration plus biomaterials leads to the best outcomes in terms of bone preservation and soft tissue stability. So in summary, I wanted to highlight the critical role of the shape of the provisional restoration in recreating a natural environment between peri-implant and periodontal soft tissue. This means that the design of the provisional can no longer be left to something that is not almost perfect. Instead, digital workflow provide a far more precise and predictable approach to achieve this soft tissue harmony. Could be for single tooth, but also for full arch restoration. And in the same way that since the very first steps of printing books have changed the world, we can say that digital workflows are transforming implantology, making outcomes more precise, predictable, and reproducible. And today we talk about the digital transformation of dentistry, reshaping the way we plan, the way we execute, and achieve predictable and aesthetic outcome. This is a real transition from traditional craftsmanship to digital workflow, and this is the next part of my lecture, and I will demonstrate how this transformation continue to shape our practice. And we begin this transition by avoiding plaster models, transforming them into virtual models. We moved away from working with spatulas and wax, and but as you all understand, this transformation is driven by different software solution, all interconnected through digital files exchanges, digital acquisition software, 3D design software, manufacturing software. And today I would like to focus specifically on the evolution of acquisition hardware and software, and because they are the foundation of this digital workflow. And one of the first major advancements was digital smile design, introducing a new way to plan prosthetic projects. But its main limitation was that it remained in 2 dimensions. But over the years, we have witnessed a true revolution in digital facial acquisition, allowing us to work in 3 dimensions with greater precision and realism. And today, in routine practice, we can achieve 3D optical scans, 3D digital copies of the patient's face and smile. And what you see here is a digital twin, the digital clone of the patient, which is made possible here in our daily practice by the Face Center system developed by Zirkonzan. And with this digital clone, we can plan virtually any treatment, whether for teeth, for implants, for bone reconstruction, for soft tissue regeneration. So let's see how it works. So for the Face Center, the patient simply sits down and we perform a facial scan, a capturing images with and without smiles to create a precise 3D digital clone. And to show you how this new technology applies to single unit restoration, I will start with this case, with Sonia's case. Sonia is 32 years old, and she suffered of a fracture of tooth 2.2 due to trauma, which also led to the development of a fistula. Tooth 2.3 was also affected, but was restorable. It was treated and placed under provisional restoration before referring a dentist sent her to us for the management of tooth 2.2. And here we generated a digital clone of Sonia, capturing her facial structure, smile, dental anatomy, and all of this in 3D. And here is how the process was carried out. So the first step, for sure, was to take a digital scan using an intraoral scanner, allowing us to obtain a 3D model of Sonia's teeth. So you are familiar with it. We start by scanning the upper, then the lower arches, and then record the occlusion. So at this stage we have now a 3D acquisition of the dental and gingival structure. And with the CBCT scan, we now have also bone and dental structure captured in 3D. So our software allows us to match the STL files from the intraoral scans with the DICOM file from the CBCT, and creating a digital model that combines soft tissue, teeth, and bone. And by integrating the STL file from the intraoral scan with the DICOM file from the CBCT, we create a complete digital representation of the patient's anatomy. Here, naturally, the lower jaw will align with the upper jaw based on the occlusion. But to fully construct the digital twin, we now match and superimpose these three elements with the STL file of the facial scan. So here, as you can see, and now here is Sonia's complete digital twin, integrating her facial scan, dental structure, and bone anatomy into a single and precise model. And I just want to show you how to achieve a perfect alignment between the STL files of the face and the teeth. We follow this specific protocol. So at this stage, the software suggests using a transfer fork, which is the only step where we still use an analog step with silicone. So here it ensures precise alignment between the facial scans and intraoral data, so bridging the gap between digital and physical references. So during the facial scan acquisition, after capturing frontal, profile, smiling views, we ask the patient to bite into silicone placed on the transfer fork. And at this stage, we are not looking for occlusion. The goal is simply to ensure that the maxillary teeth are embedded in the silicone to create a stable reference point. And then, once the maxillary teeth are positioned in the silicone, we proceed with a final facial scan acquisition while the patient holds the transfer fork in place. And this step ensures a precise match between the facial scan and the intraoral data, allowing for an accurate 3D integration of all elements. So next, we remove the teeth from the STL file generated from the scan and replace them with the plain prosthetic teeth. And this allows us to create a seamless transition from the patient's natural anatomy to the final prosthetic design. So we take the STL file of the impression and position it into the indentation of the transfer fork, which has now become a new STL file after scanning. I wanted to show you this step because this repositioning is incredibly accurate, and it's something that we didn't achieve before with DSG in the past. So now the implant planner software integrated into this workflow allow us to achieve this final image. So this integration enables us to visualize bone structure and soft tissue interaction. However, as I told you, for single unit restoration, I'm able to obtain the same information during the first appointment by using simply a retractor during the scan. And this allows us to capture all the necessary dental soft tissue details in one simple step. So here I can see once again that the supra-crestal attachment system here typically extends to 3 millimeters. And just to remind you, the literature suggests placing the implant 3 millimeters below the prospective gingival margin. So here let's see how I proceed. So to make the drilling process easier, I use the marginal gingiva as a reference. I will drill to a depth of 16 millimeters here in this case. I will add 3 millimeters for the supra-crestal attachment system. So in total, 19 millimeters from the marginal gingiva. So here I selected an implant that is 16 millimeter in length. So here I know that I will have 9 millimeters beyond the alveolar socket to support implant primary stability. And next, I will carefully analyze the width of the gap between the implant and the surrounding bone. And for Sonia's case, we have a favorable radiographic gap of more than 2 millimeters. But we must be cautious during implant placement because I don't want to reduce this gap, as we'll need sufficient space to insert biomaterial to promote good healing and tissue integration. So here the selected implant diameter is 3.3 millimeters, which is commonly used for lateral incisor due to its appropriate size for the available space here. So now I assess Sonia's implant axis, and here it's clear that the implant axis is not favorable. So the implant axis in Sonia's case is not favorable for a screw retain restoration. The root axis in Sonia's case generates a relationship with the external cortical plate that is a class 2 here in this classification, and I did not choose here to drill accordingly to the blue axis that should suggest a screw retain restoration. Instead, I wanted to drill along the red axis following the most generous bone corridor, and when it will be the moment to create the final prosthesis, I will only need to adjust the screw axis, the screw access all axis here in yellow to obtain a screw retain restoration, and this, as you know, can be done using axis correction screws and drivers. So here for sure it's reasonable to use a surgical guide. However, I also want to share with you how I've learned to guide myself free-handed, and I will now show you this technique. I observed that the intersection of the implant axis with the root, this point is easily measurable from the palatal marginal bone. Here in Sonia's case, it's 7 millimeters away, as you can see, and this technique allows for precise and personalized implant positioning without the need for a guide. So we proceed to extraction of tooth 2.2, and to achieve precise placement, I use my precision drill. So how do I do this? So to ensure the apex of the drill is aligned with the point of intersection, I will allow the drill to slide gently, keeping it pressed against the palatal cortical plate, and by doing this I can stop the drill at the 7 millimeter depth, And at this point, I will change the direction of the drill by changing the path, and I will position the drill towards the incisal edge of 2.2, as you can see here, and how it was plain before. And the apex of this precision drill is designed to prevent slipping, and this ensure that I can make the first drill with full control and accuracy, and this is very important. And I proceed with a clinical view, and I use the pilot drill first, drilling to 12 millimeter only first. Then I use a directional indicator. I validate the implant axis as I want it to be. You can see the virtual reference line, which runs from the incisal edge of 2.1 to 2.1, sorry, to the incisal edge of 2.3. And here it's easy to visualize, and it helps, and I can use it as a clear guide for a proper implant placement. And I've only used the pilot drill. This is intentional undersized drilling technique to ensure primary stability. And using my gauge, I now check the correct drilling depth, and the measurement is taken, as I told you, from the marginal gingiva, which gives a total of 19 millimeters, 16 millimeters for the implant, and 3 millimeters for the supra-crestal attachment system. I place the implant until its final position, and then the digital scanning is performed using a scan body, which is placed directly on the implant platform. This technique is well known as a direct digital impression. In contrast, we can also do indirect digital impression technique. We use a traditional transfer. The implant position is captured using a self-curing resin. And this transfer will now hold the digital analog, which will serve as the basis for the indirect digital recording. This creates a new STL file, which will be then matched with the digital working model in order to obtain virtually the implant position. Next, the provisional restoration is designed and finalized, and only once the provisional restoration is complete, I proceed to the next step. So there, a collagen membrane will be gently placed, extended up to the area in front of the fistula. I place excess biomaterial vertically to ensure a sufficient volume for optimal tissue regeneration. And then I use a tunneling instrument. I create a slight partial thickness incision at the mesial papilla, allowing the material to be positioned, the biomaterial to be positioned under. And next, I perform a U-shaped suture to secure the tissue and biomaterials, ensuring a proper stability and supporting the healing process. So here you can see at 1 week post-surgery, the healing process is good, and particularly benefiting the mesial papilla. So we had anticipated this outcome on the digital clone. So here, take a look on how the digital model predicted the mesial papilla healing, aligning with the expected result for sure at the time of modeling. The mesial papilla was partially absent, so we digitally recreated the ideal gingiva around the provisional restoration. And in this case, it was the tissue that adapted to the restoration rather than the restoration being adjusted to the exact existing tissues. And as we saw it, and from my point of view, it wasn't very difficult to have the tissues to adapt to the restoration rather than the other way around. So this is 2 months after. And just for fun, we took another optical impression after the treatment, and here is the result of Sonia, who is very happy with her smile. And I've shown you the importance of the graft effects And now I'd like to just to show you another case. This is live as I remove the provisional restoration for the first time after surgery. I show you this because the same strategy was applied here, and this is the final result. It was here essential to apply the same strategy. It was essential to avoid having short papilla in this kind of case. And for all of this case, we achieve a prosthetic solution classified as FP1 according to MISH classification. And my goal today was to demonstrate that the relevance of FP1 in terms of both aesthetic outcomes and hygiene access. But the question arises, can this FPN classification can be also applied to more complex restoration? Our ultimate goal is to restore our patient's smiles while also ensuring the longevity of implant treatments. And for those who are passionate about FP1, I look forward to meeting you in September at the EAO Congress in Monaco, where I will talk about digital strategies and open healing for FP1 success in full arch implant rehabilitation. So thank you all for your attention. We've covered a lot of ground. I hope the information shared has been helpful and maybe insightful for your practice. And if you have any further question or thought, feel free to reach out. I'm happy to continue this conversation for sure. So thank you again, and I look forward to be connecting with you all soon. Thank you, and have a great day.